Hello, everyone. My name is Antonio Derosa. I'm a faculty member at Weill Cornell, serving as the program lead for decision navigation and patient support in the Meyer Cancer Center's Office of Community Outreach and Engagement. I also serve as the Oncology Consumer Health Information Professional in the Samuel J. Wood Library. In these roles, I provide evidence-based decision navigation services and interventions, information counseling, and health literacy awareness education to promote informed decision-making among the oncology community. Today, I'll be speaking about supporting shared decision-making for breast cancer patients by promoting informed decision-making and patient engagement. So firstly, I just want to disclose I have no conflicts of interest, financial or otherwise, related to today's program or this talk. And before we get into it, I just want you to take a look at this question, answer it to the best of your ability. So I'll give you a few minutes, or a few seconds to answer that. All right, and here's the answer. The answer is B. A paternalistic view of healthcare delivery is a better facilitator for shared decision-making than value-based healthcare. So if you didn't get that on the first try, no worries. Hopefully by the end of my talk, you would have a better idea of why that's the answer. All right, so by the end of this talk, it's my hope that you have a working definition of SDM. So that's how I'll refer to shared decision-making from now on, SDM. An awareness for barriers and facilitators of the SDM process, that you'll learn an example technique for employing SDM using an effective model, and you see the benefits of SDM for your patients. All right, so SDM is a subset of the broader theory of patient-centered care, whereas patient and providers both feel mutually, are mutually partner mutually on care plan development and have communication that's effective throughout the course of the continuum of a patient's care. So both patient-centered care and shared decision-making definitions have some similarities and similar components that you can see here that I've called out on the slide. So things like information sharing, participation, preferences, interdependence, collaboration, and cultural and personal beliefs. The difference here being that SDM focuses more so on the patient as an individual and their unique process for making informed decisions in partnership with their healthcare professionals. And this is based on a number of factors like their experiences, their understanding of their disease, and their autonomy. Some patients distrust or feel uncomfortable discussing healthcare concerns with doctors who they cannot relate to on a personal level. So for example, elderly patients, patients who speak English as a second language, and those who have lower health literacy levels may feel less engaged in the decision-making process. They also have less confidence in navigating the healthcare system overall. Other patients might come from cultural backgrounds that lack a tradition of individuals making autonomous decisions, thus making it difficult for them to engage with their providers. Physicians can also unwittingly introduce barriers. Many doctors believe that they are good at identifying patient preferences, but there are enormous gaps between what patients want and what doctors think they want. For example, a physician may believe that a patient with prostate cancer's priority is to remove the prostate, while the patient's priority may be to maintain the best possible quality of life, which in their view means not undergoing surgery. The misdiagnosis of patient preferences thus becomes a deterrent to delivering patient-centered care. Moreover, doctors may unknowingly hold biases toward patients who they feel are not able to understand complex medical information. This highlights the importance of sharing information at appropriate reading and literacy levels, which requires an entirely different skill set and inquiry to effectively determine. Okay, so in order for SDM to occur successfully, there are three essential elements that must be present. The first, both the healthcare provider and the patient must recognize and acknowledge that a decision needs to be made. Next, both of these individuals must also understand the risks and benefits of each option. And thirdly, decisions must take into account both the provider's guidance and the patient's values and preferences. For some medical conditions, there's only a single treatment path forward, with patient preferences taking a more minor role in the decision-making process. Some examples of this may include surgery for appendicitis or antibiotics for bacterial infections. However, nowadays, most diagnoses have more than one medically appropriate path, all with different potential outcomes and side effects. Treatment for early stage cancers being one example of this. When more than one medical treatment exists, clinicians can facilitate SDM by encouraging patients to voice their concerns and their priorities. Okay, so what you see here is a simple model for shared decision-making, which was developed by Dr. Glyn Elwyn, who is a professor from Dartmouth and a foremost expert in the field of medical decision-making and patient engagement. He and his team have published much research on implementing shared decision-making in clinical practice and have come up with a three-step model that you see here. The first step, introducing choice. Next, describing options, often by integrating the use of patient decision support. And finally, helping patients explore preferences and make decisions. This model rests on supporting a process of deliberation and on understanding that decisions should be influenced by exploring and respecting what matters most to patients as individuals, and that this exploration, in turn, depends on them developing informed preferences. This process is rooted in conferring agency, where agency refers to the capacity of individuals to act independently and to make their own free choices. Choice talk refers to the step of making sure that patients know that reasonable options are available to them. Option talk refers to providing more detailed information on the choices available so they can weigh their options accordingly. And decision talk, finally, refers to supporting the work of considering patient preferences and deciding what is best from there collaboratively. Understanding a model like this one can lay the groundwork for practicing SDM with your patients. Speaking of practice, there are many evidence-based interventions and strategies for supporting SDM, including the use of patient decision aids, which are usually online tools used for educating patients on treatment options and presented in such a way to accommodate low literacy patients. If you're interested in learning more about patient decision aids, see the reference list at the end, as I won't be discussing specific decision aid resources in this talk. Instead, we'll be focusing our efforts on an evidence-based process called the Decision Navigation Intervention. This intervention was created by Dr. Jeff Belcora from the University of California at San Francisco. The Decision Navigation Intervention employs a process known by its acronym as SELECT. That's SLCT, standing for scribing, laddering, checking, and triaging. The SELECT process helps to initiate critical reflection in patient discussions and occurs when people think, talk, and write about issues most important to them. The steps in the SELECT process will ultimately create a written list of questions or concerns that a patient may have regarding treatment options. An individual administering the decision navigation intervention, we'll call them the facilitator, will start by allowing the patient to speak openly and freely about their diagnosis, what they know so far, what they would like to know, any gaps that can be determined. This is the scribing phase and is usually just the tip of the iceberg. Next, the facilitator will ladder specific points made by the patient. That is, they will ask the patient to elaborate or clarify any main points that were brought up in the scribing phase to get a deeper understanding of their major concerns and questions. The checking step allows the patient to think about potential preferences and questions that they may not have already mentioned or thought about. This is usually a short checklist of items prepared by the facilitator ahead of time to ensure that the full breadth of topics and concerns are being addressed. The final product is a succinct list of questions or major concerns voiced by the patient and triaged by the facilitator. That is, the facilitator distilled the main points from the notes they took during the session with the patient. This written document should be provided to the patient and their physician to facilitate improved communication and open discussion about treatment options based on the patient's self-reflection about what is most meaningful to them in order to make the best decisions about their care. So since we've just gone through an example decision-making support process and intervention, we could talk a little bit about the benefits of SDM. Having a forum to voice their preferences and understanding the risks and benefits associated with their decisions makes patients happier with the care they receive. For example, one 2017 study found that patients who participated in SDM were more knowledgeable about their condition compared to a control group, and when given their treatment of choice, reported higher levels of overall quality of life after 6 months. Additionally, these patients were far more likely to be satisfied with their treatment, with about 71% satisfied compared to about 35% of patients who did not engage in SDM. Patients who made informed decisions were also less likely to regret their treatment choices, about 5% compared to 15% of patients in the controlled group. SDM techniques can also help patients establish trust with their providers and helps providers engage and better communicate with their patients. A 2013 study assessed the relationship between African American patients and their providers using conversation guides to lead patient-physician conversations. Qualitative interview data showed patients' trust in physicians increased after using the conversation guides. Researchers further noted that while SDM can increase trust, using other specific techniques in combination with SDM was particularly effective. Specifically, mistrust of physicians among African Americans with chronic disease may partially be addressed through patient education efforts, as well as physician training in interpersonal skills and cultural competence. Other research shows that when physicians understand cultural and other personal factors of a patient, the patient is more inclined to trust the provider with their care. Lastly, research reveals that patients who are empowered to make healthcare decisions that reflect their personal preferences often report feeling more engaged in their healthcare and experience better health outcomes, like decreased anxiety, quicker recovery, and increased compliance with treatment regimens. A 2017 review of 105 studies showed that the use of decision aids reduced the number of patients that were passive in their treatment and increased patient adherence to recommended therapies. Patients also had increased knowledge, more accurate perception of risk, and reduced internal conflict about healthcare decisions. So here's a list of references and resources for my talk today. A couple here are specifically related to patient decision aids for anyone interested in learning more about those tools to support SDM with their patients. So with that, I will thank you for your time and attention.